Good morning, everyone, and thanks for joining us today. My name is Terrence Henry, and I'm the Executive Director of the Academy of Medicine, Engineering, and Science of Texas, also known as TAMEST. And we're really glad that all of you could join us today for this session on COVID-19. Before we begin, I'd like to just take a couple of moments and tell you a little bit about our organization. The Academy of Medicine, Engineering, and Science of Texas is known as TAMEST, and we support collaboration to advance research, innovation, human talent development, and business in Texas. We are composed of more than 300 members in Texas of the 3 national academies. So the National Academy of Medicine, National Academy of Engineering, and National Academy of Sciences, as well as our state's 11 Nobel laureates. We're supported by our academic member institutions in Texas, which we have 18 of, and they are represented here on this slide, as well as by our moderator today from Texas A&M University. And we are also supported by our endowment, and want to take a moment and recognize the founders of our TAMEST endowment, which allow us to continue operating today. And really want to thank them for their support to our research community and to the health and vitality of our state. Since the beginning of this pandemic, TAMEST has been holding these conversations on COVID-19 to bring together experts from across the scientific community to provide evidence-based information on the pandemic and explore opportunities to move forward through the crisis. And today's session, which we're really excited about, is going to explore ways to improve the designs of hospitals, emergency facilities, clinics, and other buildings to meet the challenges both of this pandemic and other highly communicable diseases that we may face in the future. We'd like to thank our sponsor for today's session, Lyda Hill Philanthropies. Lyda Hill Philanthropies is committed to funding transformational advances in science and nature, empowering nonprofit organizations, and improving the Texas and Colorado communities. Thank you for your support of this important session. So this will be a 1-hour session, and we're going to have 7 minutes from each speaker. Our moderator will talk a little bit more about the format once I turn it over to him in just a moment. And towards the end, we're going to have some time for audience questions. We welcome you to submit your questions throughout the session using the Q&A function on Zoom. And we'll have some time set aside towards the end to address those audience questions. I'd now like to introduce our moderator for today's session, Dr. Ray Pentecost, who is the Ronald L. Skaggs and Joseph G. Sprague Chair of Health Facility Designs and Director of the Center for Health Systems and Design at the College of Architecture at Texas A&M University. Dr. Pentecost also serves on our annual conference planning committee, which we are planning to take place in San Antonio in January 2022. So Dr. Pentecost, thank you so much for your service to TAMEST, and thank you for moderating today's session. I'll turn it over to you.
Thanks, Terrence. It's a pleasure to be with y'all today. I've so looked forward to this event because I got to put it together and choose the speakers, so I know what's coming and I'm excited. Today, 3 speakers, 3 perspectives. Tell me if you can identify with any of this. You're in a healthcare facility and something isn't working for the COVID situation. You need a quick response. How do you take care of that? Or you're with an organization that says, next time we want to do it just right, we're going to build it for communicable disease from the beginning. What would a facility designed like that from scratch look like, and how would it work? The third perspective, if we're going to do something going forward, what guidelines should we follow to make the facility the best that it can be? Those are the 3 perspectives today from our 3 speakers. Let me introduce you to all 3, and then we'll just run them in succession. First speaker is Dr. Mike Wood. Mike is the Vice President of Planning, Design, and Construction and Energy for MedXL. Some of you know MedXL is part of Ascension. Mike is a healthcare design and construction management executive leader, specializing in complex problems, programs, systems, project types, team collaboration. Mike's a physician who has migrated to the facility side of healthcare. And he understands how to integrate capital projects and clinical procedures as well as anybody I know. So as the COVID pandemic raged, Mike was responsible for finding what kind of quick response mechanism they could put together to modify lots and lots of facilities to accommodate a very special demand. Mike's going to talk about facility modification. Then we have Cliff Harvey coming up. Cliff is the Chief Planning Officer for Niagara Health in Ontario, Canada. Cliff's an architect with a design specialty expertise in healthcare facilities. Formerly with the Toronto Health Ministry, Cliff was involved in developing a healthcare facility designed from the outset to accommodate the extraordinary operating parameters of a biological communicable disease pandemic. Cliff is now associated with that facility, and he's going to share with us lessons learned, what worked, what could be done better next time. So look for that case study right in the middle. And then our third speaker is Doug Erickson. Doug is the Chief Executive Officer for the Facilities Guidelines Institute. It's a non-for-profit organization responsible for producing the guidelines for design and construction of healthcare facilities, whose mission it is to produce consensus-based guidelines in healthcare design. He's a founding board member of FGI. He's been in a leadership position with that organization since 1985. And if you attend a healthcare facility conference, you probably listen to Doug. Doug is always doing updates at those events to keep the design community in good shape with the guidelines. His latest project is a set of guidelines for emergency response facilities, emergency care situations. And he's going to talk about that project today. So 3 speakers, 3 perspectives. Facility needs quick modification, designed from the beginning for this sort of situation, and going forward, what are the guidelines that will shape these facilities? It's going to be fun. Mike, you're up.
Thanks, Ray. Had to find the mute button. Thank you very much, and honored to be here, and just a great thank you to TAMEST and fellow speakers. It's really an honor to be on the platform with Doug and Cliff, and thank you very much. As Ray said, I got about 7 minutes to explain what we had to design in probably less than 7 minutes when we got a call from our system CEO. So if you just don't mind flipping through the first slide, that'd be fantastic. The group that we organized named themselves. They had 3 different names. One I'll skip. The second one was the Avengers. And the last acronym they came up with was called FAST, Facility Assessment Support Team. And that came from a request, if you will, on a Saturday morning to respond to across our platform. Ascension is our client. So we have a very large platform, approximately, depending on how you count, 29 states, about 170 campuses, acute care campuses, somewhere around 2,000 ambulatory care facilities distributed across that same portfolio. Those requests for what do we do, how do we go through assessments, how do we separate populations, how do we keep, if you will, our patients, families, providers, associates, and frankly, our communities safe from this disease that at that moment, roughly March 10th and 11th, was relatively unknown. So we put together this team, which you see on the slide in front of you. And this team is made up of really subject matter experts, and not 1 deep, but in many cases 2 or 3 people deep from these particular areas of expertise. And it didn't start that way. I started out with calling my director of construction, and his name is Gil, and said, hey, Gil, what do you think? How fast can we assemble people? And what sorts of expertise do we need on the team? So between the 2 of us, we were able to really put together this cross-functional team. And frankly, we missed one on the first day of operation when the FAST team stood up. And we added that, and it ended up being one of the most vital members of the entire team. And that's our partner in Ascension, the infection preventionist. And then we added actually another one that doesn't appear on this slide in particular, called clinical operations. But we went through the entire spectrum from our master planning folks, our design, construction, energy folks, which actually have ended up being one of the more critical members of the team, traditional engineering, if you will, our pre-construction for cost containment and for reaching out into procurement issues, which we experienced in most of the healthcare systems that we have talked to have experienced likewise. And then talking to actually to Mr. Erickson and his team with guidelines and compliances and authorities having jurisdiction We talked to all of those different factions, if you will, as we went forward. As you can read the slide real quickly, conversion, the real charter of that team was to be able to provide guidance and governance to the conversions that were being asked of us, whether it was out in a parking lot, in an ED waiting area, ED treatment area, or back into an OR or an LDR suite. The fourth component that we had to add over time was, what do we do to those spaces that we have converted for, in our case, plus or minus 90 days? How do we get back into either restoration or permanent condition? And so the FAST team expanded its capability to really talk about restoration. I'll talk about that in just a couple of minutes. Last but not least on this slide, like most of you, we were faced with, what do we do with the cost associated with this? Very first priority is our communities, our patients, and our families. But at the end of the day, if we weren't financially and fiscally responsible on the business side of this equation, we had no mission. So we had to sustain that mission, and we had to keep track of costs, whether it was a FEMA reimbursable or not. We had to really maintain our cost structure and our cost records. So if you don't mind flipping to the next slide, thank you. Here's, I thought everyone on the call may be a little bit interested as to what do one of these conversions look like. Well, this is actually our #1 conversion. And this was done March 16 and 17 of 2020. So days after we stood up a series of national command centers. Our structure was, we set up a central national command center, and then we set up regional, which was primarily state-based command centers with our ministries, our client structure, management structure. And this was conversion #1. And this is one that we created kind of a classic, which has now become a classic, I guess, a anteroom conversion outside of an OR suite so that we could address a patient that had contracted COVID, and we could protect not only the environment, but the patient and everybody associated with the pre-op, post-op, and the procedure itself. And we were learning. As some of these, you see some of this in the lower left, we had kind of a few spirited dialogue conversations as this was taking place, and the guidance that was given by the FAST team, and how do we implement that through barrier walls. I'll have to admit duct tape, which you can see a couple of times, and had to go find a set of scrubbers with HEPA filtering on them. We can get into technical details all day long, but this team actually became a core team of a group of about 30 individuals that continuously dialogues, moves, and improves, this particular response. If you flip to the next slide, I think for folks on this call, this is where some of the meat is. These are our top lessons learned. And we have spent a lot of time in this dialogue. So instead of reading this to you, this is available to you. But the real high points are, we defaulted on, in essence, making the alteration in place, treating in place, if you will, to go back to the medical term. So more often than not, we tried to use window exhaust with no filtration. If we had to go into the return air systems, then we did other things to make sure we were heavily filtered, whether it was MERV 14 plus or whether it was HEPA filters. But we made sure that we were not going to reintroduce into the environment air from a COVID-19 situation, which is very difficult to maintain, very difficult. We did mixed use ward conversions. You can read here some of the lessons learned on that without getting into the engineering side of it. Main point on this one is use your ILSM and ICRA mechanisms. Bring your clinical staff, your infectious preventionists into this equation. You can see about the exhaust conversions, outside air, those things. Last but not least, and then I'll pass the baton here, Ray, thank you, is keep it simple. Use the KISS principle. Don't be afraid of this. Segregate your population. Keep the tools that we have available through FGI and other authorities. And for us, at least, literally hundreds of these conversions, We have done the engineering over and over and over and over. The research, the studies, we participated with the CDC. We have defaulted to filter at the source. And we have that's been a continuous debate, but one in which, as a practitioner, I'm not going to give up on. So with that, I'm available for questions, and I'd like to pass the baton on. Thanks, Ray. Appreciate it very much.
Great.
Sounds great, Mike. Mike, thanks a bunch. Cliff, you're up.
Okay. Thank you, Ray. First of all, thank you, Ray, for the invitation. Thank you, TAMEST, for the opportunity to speak with the great panelists. I always take away much more than I give to these type of sessions. So thank you to everyone for participating. We do have a unique story here that goes back to 2003. At 2003, Toronto particularly was hit by SARS. It was significant. It was the epicenter for the SARS outbreak in Canada. And at that point, I was the senior architect for the Ministry of Health in Ontario. And as a public healthcare system, we're responsible for actually funding and authorizing the construction of all hospitals in Ontario. There's about 150 hospitals in Ontario and about 120 different corporations that run them. This story is about St. Catharines and Niagara Health. And at that point, we were learning very quickly, just as we're doing through COVID, what we have to do to prepare ourselves for SARS. And at that time, we created a number of infection control practices. We started to look at how we would handle pandemics, as well as outbreaks and different types of infectious diseases. The St. Catharines Hospital was actually completed in 2012, but was started planning in as early as 2005 and 2007, was the first hospital that we built in Ontario after SARS. So there's quite a few lessons that we incorporated into this facility, and now becomes a case study in how well we did, and what are we going to learn from the perspective of how we're going to go forward with the new facility. As Ray said, my responsibility for Niagara Health is actually leading the construction of a brand new hospital in Niagara Falls, Ontario. The interesting thing about that is, while St. Catharines was the first hospital to be built after SARS, the Niagara Hospital would be the first hospital built after COVID. So what are we going to incorporate? So if you go to the next slide, just really quickly want to talk about some of the lessons that we have for, from the St. Catharines project. One of the key things is that what we implemented was a scenario planning right from the beginning for new facilities. How are you going to handle a different level of infectious diseases? Of course, I'm not talking about hospital-acquired infections. We did a number of things to move towards that, hand washing stations, all that. I'm actually talking about communicable infectious diseases like SARS, like COVID. And one of the things we did was go through different levels of preparing. We would actually do just a simple patient comes and needs to be decontaminated. Could have been something as long as a truck accident with radioactive material. How do we protect everybody in the hospital from that one patient? Then we would do the second scenario, which was, okay, we have 2 or 3 patients showing an outbreak situation in the community. Could be mumps, could be measles, something along that lines. How do we handle that and move them forward? Then we actually move into a epidemic, which is something like SARS, which is still community-based, or I would say regional-based. The last one was a pandemic. What do you do when we have to shut down the entire hospital? And so you'll see in the red bubble there, that's actually where our emergency department is. And our emergency department was prepared to handle those 4 levels of outbreaks. The interesting thing about that, so it was done from a zoning point of view, the air handling and segregation of patients, the isolation of patients, the zoning, so that we would be able to continue to handle emergency cases even when we had an outbreak situation. I will point out on the left-hand side, our outpatient mental health. I point that out because that's an assessment center for COVID within the facility. I'm going to talk about that in a minute, but I just wanted to point that out, that where that is in the actual plan. If you go to the next slide, please. You'll see that up above, we actually have our inpatient units. That red dot on both plans is the elevators. So we're able to actually transfer patients from the emergency department to the actual inpatient units without going through the hospital. And all that air, all the HVAC systems are in isolation mode so that we're actually able to contain anything that goes forward. I will say that all patients were tented that moved through that facility, but that's in the protection of the staff as well from that perspective. You'll see on the left-hand side in the blue bubble, that's actually the telemetry. That was another. So we potted our design so that we could move from level of outbreaks and be able to contain them while still looking after the patients. And now if you go to the next slide, these are the takeaways that we've learned. So what I was trying to explain is that we actually planned the hospital to take on different levels. So as you can see, the emergency planning management plan, how the building works from a wayfinding point of view. From SARS, we looked at emergency management workflows and routing for the 4 different types of outbreaks. We looked at negative pressure rooms and units and surge capacity. Now, here's where we now break down between 2003 and 2012 when we opened up the facility, and today, you'll notice I say surge capacity where? Our emergency management plans are somewhere on a shelf that nobody seemed to remember where they were. So a lot of this had to be all relearned. And I'll say that is that when they were talking about surge capacity, they had to start going through and counting where we could actually put people. Even though that was a part of the original design, it seemed to have lost its way between when we finished the building and actually the outbreak. So what we were able to do is start to plan again, what is the emergency management plan? How is the building to be used? The second part of that is the fact is that the emergency department is completely in negative pressure. So we could actually turn the whole thing into a negative pressure. That took us about a week to figure that out because the facility management team had changed so much, they didn't know exactly how to do that. So again, this is a lessons learned, is that this has to be well documented and well executed. We had all the things in there from a design perspective, but this is where we actually have to make sure that the team understands how to use the facility. The things that I just want to point out, the emerging issues is the fact is that now we have to really understand how the system works. And we're just one hospital. We have 5 hospitals that we look after. We made one the infectious disease hospital and allowed the other ones to maintain non-essential services as best we could. So essential and non-essential services, how do we have that continuous? Particularly because we're taking 3 hospitals, combining it together. We want to make sure we can still do our essential services like cancer surgery while we're still providing. Big thing was supplies. We're just-in-time delivery, but we went up 300% in supplies. So we really had to look at how we use supplies, where they are. Everybody on the COVID units had to be in scrubs. Our Scrub X machine is located in the surgery. We don't have change rooms associated with it. Really have to think about that. Screening and technology, and I think that's really important. How we actually separate the patients that come into our facilities. The St. Catherine's Project had that capability, but because it was the infectious disease hospital, it was shut down completely. So it didn't get to execute that. Our next hospital, we want to be able to separate those. Virtual care, I think everybody understands that one. The one thing that SARS didn't anticipate, because SARS wasn't as communicable as COVID is physical distancing. Patients to staff, staff to staff, family visiting policy. So staff to staff is important because even in our team rooms, we had to separate our staff. Did we have enough room for that? Negative pressure, I talked about that, being scalable, going from rooms to whole units. And the emergence of infection and prevention and control technology like UV and materials. Those are coming forward and we're incorporating them in the facility. The last thing I'll mention is assessment centers. What we didn't anticipate, we anticipated that everybody would go through the emergency department, and that's not what happened. Everybody went through an assessment center. And so our assessment center, which was actually the mental health unit, wasn't prepared to take the amount of traffic that was going through. We had staff members who were actually acting as traffic police, trying to get cars around the loading docks, which was located by there. So these are lessons that we're building now into the new facility, which I think are fundamental because we need to be prepared. The biggest impact on COVID, aside from the immediate impact of the disease, is the impact on care, our ability to continue to give care in the hospitals as they're designed to, and being able to do central and non-essential care to maintain people's health throughout this whole pandemic. So I'm now going to pass it over to Doug, and thank you very much for the opportunity to speak.
Thanks, Cliff. Terrific. Doug, you're up.
Thanks, Ray. And it's a pleasure to be with everybody today, and especially be able to speak with Mike and with Cliff and present with them. Both of them had great presentations, a lot of which we've been taking advantage of within the Facility Guidelines Institute. Back in March, after COVID started to rear its ugly head, our board of directors they charged me and my staff with developing what we call emergency conditions guidelines. And so I call it the Emergency Conditions Project because it's much more than just guidelines. So what we're doing is we are fast tracking a typical process that takes 4 years. We are doing it within about 8 months, 9 months, which is a lot of pressure to be able to come up with what we call properly vetted, properly publicly reviewed recommendations. We do have 2 different products we're producing. One is a white paper that is going to be looking at best practice, case studies, solutions that have been put into place as far as COVID is concerned, along with weather-related and other man-made types of emergencies. That'll be about 500 to 800 pages long. And we're also going to be producing a recommended series of guidelines to be adopted by state agencies. And that could be as few as maybe 1 to 2 pages long. So we're really not pushing for a lot of what I would consider standards. We're really trying to put out what we think are some of the best solutions that have been put into place with regards to both COVID and other emergency and man-made related emergencies. So as you can see there on this slide, we are looking at 8 different subcommittees that have produced chapters within the new white paper. So anything from looking at risk assessment, because once again, one size does not fit all on this. You're going to have to look at zone maps for tornadoes, for hurricanes, for let's say for flooding, for Arctic blast, for wildfires, etc. We're looking at some of the issues of surge. I'll go through that in a second with you. But really trying to figure out, as Mike and Cliff are talking about, what do we need in order to put something in the hands of the authorities having jurisdiction, along with the owners and the designers. We found there was very little out there when this outbreak took place back out in late February, early March. Next slide. One of the key things that we've got going on right now, and we're struggling with as a leadership within both the Health Guidelines Revision Committee, which is the organization responsible for producing the guidelines, and within the board of directors of FGIs, where do we put this information? If we include it in the new standards that we are introducing for 2022 and incorporate it into those guidelines, we think we may find some pushback from state hospital associations, from maybe the authority having jurisdictions on adopting the 2022 because they think maybe we have gone too far. Don't know. That's yet to be seen. We have another where we can produce it as a freestanding emergency conditions guideline. And that means it's, you know, a very small document, one that could be adopted by state agencies along with the 2022 document or documents. As you well know, the great state of Texas has not yet adopted the guidelines, but there are plans in place right now to adopt the 2018 that has been, I believe it's been delayed somewhat because of COVID-19 and all of the pressures on your Department of Public Health. The third would be as a supplement to, which would just be a series kind of white paper to say, consider these things as you're doing your planning, design, and construction of new facilities. So next slide. Some of the major recommendations coming out of the ECC project for hospitals would be a mandatory incident command center in all healthcare facilities. Some place where people can go, gather, and share information and really command what's going on within the organization. We don't have that in our current guidelines. However, a lot of organizations do have that incorporated into their standards, such as NFPA, ICC, etc. We're also looking at, the whole issue of the anticipated hazard associated with your geographic location. So that would be asking the design community, the owner community, to make sure that they are going through a risk assessment, looking at what we've produced and what is the potential for whatever the case may be. It could be a security event. It may be, as I said, a flood. It could be, once again, the next pandemic that's coming down the line. Another big one, and Cliff, this is something that I'm sure you're very familiar with, is single-bedded rooms for resident rooms. And in Canada, 90% of the deaths due to COVID were as a result of nursing homes, of both residents and healthcare workers within those nursing facilities. So our organization is going to be looking at recommending single-bedded rooms for residents unless the functional program dictates otherwise, and then you could put in a double-bedded room. The next is, how do you convert non-clinical space to patient care space quickly? Do you put in the necessary electrical outlets, emergency power outlets? Do you put in your medical gas system outlets in your, let's say, meeting spaces, in your educational conference rooms, wherever you think you're going to be surging in order to take care of patients in those non-clinical spaces? We're also, of course, looking at being able to convert the single-bedded room to the double-bedded room in a surge capacity situation. And then last but not least is some means to locate the IV pumps, monitors outside of the patient rooms, so you cut down on the number of entrances into those general med surg rooms for just to reset an alarm or to put a new IV solution bag on the IV pole. We had a lot of situations where we were running this tubing and running the cord, the monitoring cords, along with ventilator tubing through the door openings, the corridor door opening, and we had situations where people were stepping on them. Of course, casters going across them, couldn't close doors, couldn't close the door and keep the negative pressure within the room with the door open. So that's one of the other major recommendations. So with that, it's a very interesting process and program we're going through. Hope to have something available by the end of November, middle of December. And then the new guidelines would be published by the beginning of 2022. So with that, I'll turn it back over to Terrence or to Ray.
Terrific, Doug. Thanks very, very much. I have some questions, and perhaps the panelists will have comments to make to each other, questions of each other, but let me sort of begin the conversation. Mike, you talked about the ability of the FAST team to respond quickly to requests for help that came in from across the country. Tell us about how that FAST response worked.
3 sets of filters. So the request would come through, I'll call it the local ministry or the local hospital system, through their incident command. Then it would be passed forward to our national command center and reviewed again. Then it would go to the FAST team. And what we were trying to do was line up a facility requirement with a clinical requirement. And as the FAST team received that, what we found out really quickly is they had to participate in all levels of the conversation, or members of the team. What that did, we initially took roughly a day or two to respond to people, and we found out, frankly, that wasn't quick enough. We've gotten it down to, in many cases, it's literally a 15-minute turnaround. The average is less than an hour over roughly 240 conversions. So what we have found is that multidisciplinary team integrated, collaborated very rapidly, they get a request through a central email system, if you will. Two of the critical members are alerted immediately through a text. They then assemble themselves and break out of whatever their normal schedule or conversation is at the moment. And they're usually on the phone in less than 5 minutes with each other.
So it's like an emergency response. If you were at a meal or doing a task, if they get that alert, they quickly assemble and deal with the issue.
Correct. Yeah, and it's really pretty simple at the end of the day. That, again, returning to the KISS principle, we know that at that moment, we've got patients, families, and providers, associates at risk. And it wouldn't have gotten elevated if it didn't need rather immediate or urgent attention.
So, Cliff, when you hear stories about facilities needing to modify things and needing a quick response and this hierarchy of priority, in your experience at your new hospital, how much did you feel like you had to fix, or did it pretty much work like you wanted it to?
It actually worked, well, I'll say it worked fairly well in terms of the things that needed to be fixed in terms of basically just dealing with physical separation, a lot of plexiglass everywhere in terms of anticipating that. We just had not anticipated the physical distancing aspect of it from an infection control in terms of HVAC systems, isolation, understanding those things. It worked fairly well. What was interesting, we do have a comparison. So I mentioned that we actually have 5 hospitals and one was designated the COVID center. That didn't stop patients from coming to the emergency department. The other ones where they would be held and looked at and then transferred if they were COVID positive. They pose more problems. And I would expect they're the problems that Mike's talking about, because they're older facilities, multi-bed facilities, didn't have the HVAC system. And as a comparison, we tried to make sure we pushed as far as we could everybody towards the St. Catharines site. And that's a lesson, because I think, as I mentioned, in Ontario, there's 150 facilities. We're one of the systems that has 5 different hospitals, but a lot of the systems only have 1 hospital, and they had to make do. A lesson learned and a takeaway is, as we move into the second COVID episode, as a region, we started to work together to actually designate capacity and to be able to move patients. Something that we saw actually in France, where Paris started to take their patients and move them by train out into the community hospitals around Paris. And that's one of the things that we're learning. So we can actually do that. And I think that's one of the planning elements for future hospitals. If you don't have the capability to be able to be a COVID center, partner with somebody who does, and be able to work that way in these kind of pandemic situations.
Did you experience that, Mike, in your network?
We did, and Cliff, well stated. And where we have multiple hospitals in a larger community, Jacksonville, Florida comes to mind for the Ascension system. We had to do the same thing. We had to learn to designate and, in essence, triage and move. The other thing I picked up that we did a lot of in the FAST team is what you mentioned. We had to teach our facility operations folks to relearn how to run the building. We found in a lot of cases, it was designed appropriately. It actually was designed for these kinds of conversions, if you want to call them that. But somebody had put a set screw in a damper, or somebody had turned the building automation system into, their personal computer playground and turned off controls that had been turned on for, very good reasons. And Doug has lived through many of those conversations where we've talked with the FGI folks and gone, we designed it for this, for goodness sake. Turn the dial back to what's the original setting.
So Doug, I'm curious, as you and the people at FGI look at how facilities were trying to respond to this situation, many of them designed appropriately, no doubt, according to the guidelines, but somehow in the management, not exactly performing the way they should. I have 2 questions that sort of fall out of that. One is, what can you suggest when the facility, the design, the construction people do everything they know how to do to get it right, and management doesn't play along. There's got to be some people on the call that are living in that world. The other question that I have is sort of a higher altitude. These facilities that have followed guidelines for years and years and years, at what point did something in the COVID pandemic trigger the alarm in your mind? What we have currently is not adequate. We need yet another set of suggestions, best practices, case studies, guidelines, call them what you will. But at what point did something trigger that said, what we have doesn't address this? Or what was the situation that told you to mobilize?
Oh, all good questions, Mike. And the first one really should be Mike Wood, because, but as far as getting management and upper management to truly listen to what the folks in the trenches are trying to accomplish, I mean, that is just a hurdle that every organization has to try and overcome. We, of course, have standards out there, not only the Facility Guidelines Institute, but NFPA 99, and other organizations that have tried to put the parts and pieces into place to make that a successful healthcare, physical environment that will be able to handle the kinds of emergencies and situations we have. I don't have the magic bullet for that one, though. Okay, one of the reasons why you have standards is to require certain things. And I know when I was with the American Society for Healthcare Engineering and American Hospital Association, I had many members come to me and say, Doug, stop whittling away at the standards. If you take it out of the standard, it is now out of my budget. It is now not something I will be able to achieve because upper management is not going to give me the money to do so. So that segues into your next question. What we're trying to do is to really look at all of these solutions as a result of COVID. And we're trying to figure out, what do we want to codify in order so that states can adopt us and mandate that you put in. And I'm just going to use an example. I worked on the Joplin Replacement Hospital in Joplin, Missouri, after the tornado completely wiped it out. Every window in that facility was busted out, shards of glass everywhere. If I had my way, in Tornado Alley, you would have laminated glass in all of those openings. It's not that expensive. Okay, but if you don't mandate that, you don't get it. But once again, on the flip side, what do you do as a healthcare organization when you feel as if you don't have that extra dollar to put into the facility to protect that particular scenario? So we are continually, it's that scale, Ray, of what you think needs to go in and be mandated versus what's not going to be able to go in because it's too expensive. And I don't want to take too much more time, but we've got 140 people working on this in emergency conditions project, all volunteers. We have a public review process coming up at the end of our white paper to let the public review it. And then, of course, it's going to be up to the various authorities having jurisdiction to see if they want to mandate it or not. I don't know if I got to the exact crux of your question, but I think that's the best I can do at this point in time.
No, I understand it's a moving target, and thank you for sharing that. I guess a question that I have for all of you, because you're all living this question at some point. What price should we expect to pay for reserve? Do we build in reserve capacity, reserve performance, reserve space? How do you budget? How do you estimate the cost of reserve? How do you plan for that?
I'll take that, Ray, because I did it for Joplin. And what we did as a consultant to the management is say, you've got three different options. One, you can do the life safety and protect the patients and get the patients into the proper locations as quickly as possible and not have a disaster on your hands. Second one would be business continuity. Are we going to be able to continue to operate this healthcare facility, and what do we want to keep up and running again? Is it the emergency department? Is it imaging? Is it the patient care areas? What do you want to have in place? And then the fourth one is, do you want to retain this building in the condition it is today? The first option, number one, was a 3% increase in construction cost. The second one was a 5% increase in construction cost for business continuity. The third one was an 8% increase in construction cost to keep the building intact. And management went for the 8%. They said, why do we want to throw away a $350 million building and have to rebuild? And now I'll hand it over to Mike and Cliff to talk about more of the COVID experience.
Good.
Cliff, you built it. I'm converting it.
Exactly.
It's an excellent question. I'm not unmuted, am I? Okay. It's an excellent question because I don't think St. Catherine's costs more with the changes that we made in there, because we actually have used them from implemented. Because the argument is that it's just not about a pandemic. It's about infection control in a hospital too, and negative pressure. It's about hand washing. It's about a whole bunch of things that we put in that we're prepared for. The thing that we weren't prepared for is we weren't prepared for a pandemic to shut down the system in anticipation of what had happened in Italy. Now, it never happened here in Ontario. I mean, I can talk about on the number of emergency facilities, convention centers that were transformed. We talked about changing hospitals. That never occurred because we had the capacity. And there are some ideas that we have the capacity because we had prepared for SARS. And my business case really was, I have people, colleagues who have built temporary facilities in their parking lot at the cost of a couple $1 million, be $6, $7, $8 million for that. What is $6 or $7, $8 million in the initial investment into a facility for capacity, for additional capacity, be able to turn your PACU or even your cafeteria into surge capacity? Like, if I look at what we've spent on this COVID, I think we can make an argument that the cost is, we've spent it, and we probably could have done a much better job if we had anticipated really what a pandemic looked like. I mean, the lessons learned here should not be lost. The idea that there'll be other things coming our way, I expect it. We've all lived through H1N1. We lived through Ebola. I was in the States at the time with a bunch of design colleagues when Ebola was a major issue, and I saw this same reaction happen. So to answer your question, there is a cost, but I think if we're innovative as designers, as engineers, we can find solutions to reduce the cost in the long term when we look at the impact of what it would do. I'll just give one last example. We're looking at doing 100% outdoor air as a facility. In our climate, it is being challenged, but Humber Hospital, which was just built and opened 4 years ago, has 100% outdoor air. So it's achievable. What does that mean for recirculation? I mean, we're talking about increased filtration and a whole bunch of other things that have cost to it. Well, what is the cost to do outdoor air? Because I'll just put a plug in here. We're also trying to be one of the first well-certified hospitals in Canada. And air quality matters not only in COVID, but in day-to-day operations. So can we get the benefit of what we have to do for COVID, but also do that in our day-to-day operations as well?
Good responses. Mike, anything to add?
Not much. I'd just say ditto. Our experience has been, quite frankly, minimal cost. People were telling us that we would invest hundreds of millions of dollars in this, in our conversions, and that number is a factor of, 1 or 2 million, and that's our reality. It's not hundreds. We had to turn on machines and take set screws out of place and reprogram our building automation system to operate like it was designed to operate. More often than not, that's what it amounts to. And like Cliff, we are trying to learn as fast as we can and institute any changes related to design on any ongoing or going forward projects that we have right now. We're actually in the process of doing that with 3 or 4 major projects where we're trying to incorporate everything that we're participating with Doug and the ECC team and, you know, folks like Cliff, and trying to learn as quickly as we can and make our revisions so that they are no cost, or even in a couple of cases, less cost, because we know what we're doing ahead of time.
All right,
Hey, Ray, before we get to
Yeah.
the next question, just want to let you know that as of was late Monday, CDC has identified COVID-19 as an airborne contaminant, which means that it's gone from the contact-borne and heavy droplet nuclei of 3 feet, 4 feet, to where now this will exist in the air for a longer period of time. The epidemiologist I talked to yesterday said that he doesn't believe it's going to migrate into the ventilation system. Cliff has heard this many times with regards to SARS and how it's going to be transmitted. But I think this is going to be a game changer in how we're going to be designing our ventilation systems from here on out. I just want to add that in.
Thanks, Doug. It's current, and that's great. We've got a couple of cues in the Q&A, a couple of questions. One is lengthy, but I think what the point of the question is, it's about having timely information about knowing that this problem is happening around us. To what extent would a more timely alert to this situation be helpful to what y'all are doing in health facilities?
I will volunteer. That's paramount. You know, call it an early warning system. I think it's pretty evident on a worldwide scale, not just a US healthcare system or a Canadian healthcare system scale, that we have a much better alert system. Hey, this is something we're seeing. It's originating from here, we believe. It may or may not be transmitted by these means. You know, in essence, pay attention.
Mm-hmm.
You know, don't push the big red button yet, but pay attention, know what's going on. And I think we have to, as a set of healthcare systems across the globe, I think we have to create a process and a system that will tell us that, just like we have with hurricanes, just like we have with earthquakes or tidal waves or other, you know, natural events that create epidemics or, you know, actions, if you will. They have no sense of a boundary. They don't know whether they're going to Ontario or they're going to, you know, over to Alberta. There is no boundary to natural disasters. They don't, you know, they don't honor those things. We have to figure out how we, as a healthcare system across the globe, participate in a better early warning system and conversation. Hands down. I think that is, it's not just a US thing or a Canadian thing or a UK thing.
Maybe can I add to that as well? Because this is a plug for Doug and FGI, and up here in Canada, of course, that's the Canadian Standards Association, because they are a collective memory. And I highly, to Doug's last point about actually getting these things put into writing, so for future generations. I said my kids laughed at me because back in January, I bought a whole bunch of hand sanitizer and Lysol wipes. And before anything happened in Ontario, I went out and filled our freezer full of frozen food. And they laughed at me, but it wasn't necessarily I knew what was going to happen. It was the fact is that I had gone through SARS and I knew what potentially could happen. But I didn't expect it. I did not expect COVID to be where it went, because we dealt with SARS, and I thought we were prepared for SARS, but we weren't prepared for COVID. So from my perspective, early warning is absolutely key, and being prepared and not losing our collective knowledge. So it's our responsibility of our generation, as we work on these standards, as we build our hospitals, that we leave a legacy so that it can be better in the future. So early warning is one of it, but also not losing our memory. So hands out to FDI for the work they do, because that's going to help us get better.
I appreciate that, Cliff. And that's one of our mantras, is we really cannot react to the immediate. When it happens, you know, we are not the ones to go to, but we are the collective memory. And if we can put all of this into white paper standards to where I don't get the call from the Rhode Island State Authority having jurisdiction going, Doug, what do? We don't know what to do. We now can say, we do have something for you. Here it is. There are a series of recommendations, and there's a series of standards that you can follow.
Let me jump in. Thanks, Doug and Cliff and Mike. So far, we have one last question and just about time for that, so I'll throw it out. How well does a facility that's been designed, and Cliff, you touched on this, specifically for infection, it could work for other sorts of infections, but really it's about infection and a lot of best practices. But how well do the facilities that respond to specialized design, or Doug, to the new guidelines for emergency services, how well do those respond to other sorts of major disasters, hurricanes, tornadoes, earthquakes, fires, major displacements, climate issues? How well do these guidelines help facilities be more responsive to those kinds of special cases, those surging demands in certain areas?
Well, I'll start out very quickly and say it's lessons learned, and it's capturing, as Cliff said, that collective intelligence and memory of what we need to do and how we need to strengthen the infrastructure, the backbone, whatever it is that has to be done in order to withstand that hurricane, tornado, earthquake, etc. That's one of the reasons we did not just write the standards on COVID-19. We wrote standards for all man-made and weather-related events. This will give people a roadmap, whether it's codified or not, but a roadmap as to what to think about as the design is being considered and as the owner is putting input into that design of the new healthcare facility.
I would echo that. As Doug knows, our system that we serve covers basically the eastern U.S. So we have a whole lot of healthcare that's delivered in both Tornado Alley and in the hurricane zone. And I would say we are very well prepared for those, but we were not prepared, even though we thought we were, for, in essence, a medical pandemic. Even though, again, we thought we were, we used the code, we built to the code, if you will, and we practiced to the code. But like Cliff has alluded to, there were several things that caught us by surprise. The social distancing, 4 people in an elevator, just typical movement throughout the facility. We were not prepared to separate populations to the degree we now know that we need to. So.
Maybe, I know we're running short, so I just want to put one idea in front of everybody, because I think this is something that we're doing new on the facility side. Everybody who's planned a hospital knows about master programming and projecting future clinical needs. We're actually doing a resiliency plan. So we're looking at weather patterns that we expect in our area over the next 30 years, because we're trapped between Lake Ontario and Lake Erie, and if you know Buffalo's weather, we have extreme weather all the time. So we're actually using that to do our planning, to know what threats we have to plan for to build a new facility. So thank you.
Terrence?
Thanks very much, everyone. And thank you, Ray, for hosting and moderating our session today. This was really fascinating, and obviously have a lot of work to do as a scientific community to not just respond to this pandemic, but prepare for future ones. I want to thank everyone for joining us today. We're going to have a follow-up email that goes out tomorrow that will have a link to the video of the session, as well as a link to the speaker slides. You'll get a survey pop up when you close your Zoom. So if you have a chance to fill that out and give us some feedback, we'd love to hear it. And real quickly, I'll just preview our next upcoming session in this series about responding to the COVID-19 pandemic. Dr. Carlos Roberto Jaén from UT Health San Antonio, one of our TAMEST members, is going to lead us through a session that's going to focus on improving healthcare access for Texans, both during and after COVID-19. Obviously, this is a challenge that preceded the pandemic, but has certainly become even more challenging today. And we have 3 speakers for that session: Sue Bornstein from the Texas Medical Home Initiative, Jennifer DeVoe from the Oregon Health and Science University, and Winston Liao from University of Houston. That'll be on Tuesday, November 10th. We're going to do that one in the afternoon from 1 o'clock p.m. to 2 p.m. Central. And we'll hope that you can join us for that. You'll also get a link to register for that session in the follow-up email tomorrow. That's our time for today. I want to again thank our moderator and all of our speakers for this very informative session. And thank you to all of you for joining us. Please be safe, and we hope to see you next time. That concludes our session for today. Thank you.